Greetings and welcome to the Leukemia and Lymphoma Society's Living with Hairy Cell Leukemia education program. On behalf of the Leukemia and Lymphoma Society, I'd like to welcome you. We're fortunate to have as our presenter Dr. Michael Griever, one of the nation's leading experts in hairy cell leukemia. We appreciate his dedication to supporting our mission and his commitment to caring for patients living with blood cancers. We would like to thank AstraZeneca for their support of this program. Dr. Michael Griever is Professor Emeritus, Internal Medicine, Hematology at The Ohio State University in Columbus, Ohio. We thank Dr. Griever for volunteering his time and sharing his knowledge with us. Dr. Griever, I'm now privileged to turn the program over to you.
Well, thank you, and this is a wonderful opportunity to discuss all the progress that has been made in the management of patients with this disease. On this slide, I'm presenting my financial disclosures in the interest of transparency. Hairy cell leukemia is a rare form of adult chronic leukemia. Over the past 60 years, we have witnessed tremendous progress in the management of the patients with this illness. While the average survival in 1984 was approximately 4 to 5 years, our patients currently now live a normal life. Furthermore, they live as long as they would have if they did not have leukemia. The first descriptions of this disease were initially reported in 1956 by Dr. Gosselin and colleagues. Dr. Bertha Bronckley and colleagues at Ohio State University described the multiple features of this disease and established the fact that this is a separate clinical entity in 1958. This is a picture of Dr. Bertha Bronckley, who was a professor of internal medicine and hematology at Ohio State University when she described this illness. On this slide, we can see the characteristic leukemic cells, and I would like to just point out that the edges of these cells have irregular projections that have been the reason that this disease was called hairy cell leukemia. These two white blood cells are presented from the peripheral blood smear, and you can see the red blood cells that are surrounding these two leukemic cells. The clinical features of this disease are listed on this slide. There's an unexplained, remarkable male predominance with approximately 4 men to every woman who has this disease. The median age of patients who are diagnosed with this disease is 55 years, but patients are actually diagnosed with the entire spectrum, going from early 20s all the way up to the 80s, but the median age is 55 years. The symptoms are often related to fatigue and frequently related to infection. Infection is one of the leading causes of death in patients with hairy cell leukemia, and therefore it's important that we realize that some patients, approximately 15%, will present with infection at the time of the diagnosis. On physical examination, we often find an enlarged spleen. In the original description of this disease, the spleen was massively enlarged in up to 70 to 80% of the patients. In the current era, there's earlier diagnosis, and so many patients now present with a spleen that's only mildly enlarged or not enlarged at all. Patients often present with low blood counts, and this is referred to as cytopenia. The low blood counts will involve the red blood cells, and that's anemia. The white blood cells, which fight infection, are often low, as well are the platelets, which are important to prevent bleeding. The diagnosis is made by looking at the blood smear, as we've shown you in a few slides ago, and then also to do a bone marrow biopsy to document the extent of involvement of the hairy cell leukemia in the bone marrow. It's very important that the diagnosis is confirmed by looking for markers on the surface of those cells. And this is done by the use of the flow cytometer. The blood is characteristically showing the 4 markers identified on this slide: CD11C, CD25, CD103, and CD123. In 2011, another marker of this disease was identified called the BRAF mutation, and we'll talk about that a little bit later. The manifestations of hairy cell leukemia at the time the patients present are listed on this slide. Fatigue and symptoms related to anemia are often gradual in onset, and so patients can present with significant anemia that has come on gradually. Fatigue, however, is one of the most common symptoms. Because the platelets are often low at the time of diagnosis, the patient may experience easy bruising or bleeding. As I stated before, infection is one of the most serious consequences of a low infection-fighting cell called a granulocyte. And these cells are often referred to as neutrophils. And so infection is one of the presenting symptoms in many patients whenever they come and present to the doctor. One other infection that can present a problem for patients is the reactivation of herpes zoster or shingles. This viral illness is often experienced as chickenpox in patients whenever they were children. When patients with hairy cell leukemia present to their doctor, their immune system is compromised, and then they therefore sometimes will have a reactivation of this viral infection in the form of painful blisters called shingles. There are other symptoms and signs of hairy cell leukemia that are less frequent at the time of diagnosis. Some of these are listed on this slide as vasculitis, which can present as a rash on various parts of the body. There's also a rheumatoid-like arthritis, and patients can sometimes present with painful joints, and this inflammation in the joints can be migratory or present in several different locations. Patients can also present with low platelets that are due to antibodies directed against the platelets, and this is called immune thrombocytopenia. Finally, we do see patients who have bone pain, and there can be some destructive lesions within the skeleton, and this has to be carefully evaluated to rule out other diseases that can affect the bone. When the decision is made to treat, an extensive clinical judgment is involved. First of all, it's extremely important to confirm the diagnosis. Classic hairy cell leukemia is identified by those markers on the leukemic cells that we discussed earlier. The other marker, which is found in approximately 90% of patients with classic hairy cell leukemia, is the expression of this BRAF mutation. The patients who have the variant of hairy cell leukemia have different markers and are negative for the BRAF mutation. The reason it's very important to make this distinction is that the response and the duration of remission for the patients with the more common classic hairy cell leukemia is much better than for patients who have the variant of hairy cell leukemia. Patients with the variant of hairy cell leukemia can still be effectively treated, but they run into problems with relapse and failure to achieve the sustained remissions that we see in patients with classic hairy cell leukemia. In general, it's felt that the frequency of hairy cell leukemia breaks down as follows. About 10% of the patients will have the variant of hairy cell leukemia, and about 90% of the patients will have classic hairy cell leukemia. The distinction of these two entities is so important that the World Health Organization actually declared that the hairy cell leukemia variant is a completely separate entity and is not the same as classic hairy cell leukemia. So these are two separate entities. And it's very important to define which of the entities is involved with your patient's case. About 10% of patients with hairy cell leukemia do not require immediate treatment. However, though, they do require close follow-up. This is sometimes concerning to the patients because they were told that they have a diagnosis of leukemia, and we then tell them, about 10% of the patients, we're going to follow you very closely, but we don't think that we need to initiate therapy right now. One of the reasons that this is hard for patients to understand is that if they get the diagnosis of leukemia, they want to make sure that they get things treated and get things under control. What we tell them is that the earlier treatment is not going to cure them of the disease. However, we do have effective therapy that controls the disease. The chemotherapy and the treatments that we use further can suppress the immune system and the blood counts, and therefore, if patients present with hairy cell leukemia and have a reasonable blood count, we follow them closely because we don't want to add further immunosuppressive therapy until it is necessary. When we follow them, though, we follow their blood counts because if we see that they're trending down, we want to initiate therapy before they get to be too low. Patients with active infection need to be approached very carefully, and the infection should be treated first, if possible, before initiating any therapy for the hairy cell leukemia. The treatments that are used for hairy cell leukemia, either cladribine or pennistatin, can further lower the blood counts. And so if somebody has an active infection, you want to get the infection under control if possible before compounding the situation by lowering their infection-fighting cells. When cladribine is used to treat this disease, it has a very high response rate and success rate. Patients will, however, see a decline in their infection-fighting cells that can last for weeks and sometimes beyond a month. Therefore, when the initial studies with cladribine were done, patients who had an active infection were not enrolled in those studies. Therefore, we believe that cladribine is a highly effective treatment for most patients with hairy cell leukemia. However, if patients have an active infection, we don't recommend initiating cladribine until the infection is either cleared or controlled, and then we would think of other treatment strategies to try and get the disease under control if the infection can't be actively eradicated. The other planning could involve the use of other agents that are effective in hairy cell leukemia that don't lower the blood count quite as much as cladribine. It's important before starting therapy to get a careful assessment of the kidney function, and this can be done through checking blood work. Also, it's important to know whether or not the patient ever had a history of hepatitis because the drugs that are used to treat this disease are cleared from the body through the kidney, and therefore if there's any impairment in kidney function, it limits the use of some of the major drugs to treat this disease. In patients who have had a prior history of hepatitis, their clinical course needs to be followed very carefully because the treatment of hairy cell leukemia is immunosuppressive, and sometimes that can reactivate the hepatitis and would require cooperation with a hepatologist to manage the patient carefully. We believe that bone marrow biopsies at the beginning of treatment and after completion of therapy have value. The reason that we do the bone marrow at the initial point of treatment is to confirm the diagnosis and to make sure that we understand everything that could possibly contribute to the lowered blood counts. After completing therapy, we want to know how much residual disease is left. There is an approach that a complete remission is defined as seeing no hairy cell leukemia in the bone marrow biopsy and restoration of normal blood counts. There's also a term called minimal residual disease where small amounts of hairy cell leukemia can be identified in a bone marrow with the use of special stains called immunohistochemical stains. And so this issue as to whether or not the definition of the marrow at the time the therapy has been completed shows residual hairy cell leukemia or residual disease that's only identified using these special immunohistochemical stains is important. It's important because the more disease that's present in the bone marrow, there may be a need for additional therapy. The natural history of this disease before 1984 was that it was clearly incurable and it did not respond to the chemotherapies that were available at that time. And the reason for this were that the chemotherapy agents were called DNA damaging agents or alkylating agents. The bone marrow involvement with hairy cell leukemia at the time of diagnosis is usually very extensive. And so the use of alkylating agents, which can damage the DNA of the normal cells, would really make the blood counts go very low and the leukemia did not respond very well. And so patients were often harmed by using intensive chemotherapy. At that time, the approach to patients who had low blood counts was to remove the spleen. The removal of the spleen would result in improvement of the blood counts in many of the patients and also relieve some of the pressure and abdominal discomfort that the patients experienced from an enlarged spleen. This was the most commonly used treatment up until 1984. In the time frame of the 1980s, the median survival of patients was between 4 and 5 years. And as we stated before, most of the deaths were due to either infection or very low blood counts and bleeding. There was also an awareness that there was an increase in second malignancies in about 3 to 10% of patients with hairy cell leukemia, probably resulting from the immune suppression that goes along with the disease itself.